According to the new study of Hitler's DNA, researchers suggest that the myths about Hitler's micropenis, low testosterone, and one testis may not be myths at all. According to the analysis of Hitler's genetics, he may have had Kallmann syndrome, which is a form of congenital hypogonadistropic hypogonadism. His DNA was reportedly obtained from the blood-stained sofa in the Berlin bunker where Hitler died on the 30th of April 1945. Kallmann syndrome is a form of congenital hypogonadistropic hypogonadism, which means the brain fails to release enough gonadotropin-releasing hormone. Because of this, the person has low sex hormones, delayed puberty, and infertility. It is about 4 times more common in men. This disease becomes noticeable later in life, at the time of puberty, not in early childhood. The child seems completely normal, but puberty is delayed. Literally almost 100% of people with Kallmann syndrome have 2 universal signs. The first is hypogonadism, seen in almost 100% of cases. The second is absent or reduced smell, also in almost 100% of cases. Such people almost always have delayed or absent puberty because the brain fails to produce gonadotropin-releasing hormone, GnRH. The loss of smell happens because during fetal development, the olfactory bulbs and the GnRH neurons fail to migrate from the nasal region to the brain, and this is why the loss of smell and hormonal production failure occur at the same time. Boys usually have micropenis in about 60% of cases, because genital growth requires testosterone. They also have undescended testicles in about 40% of cases, because testicular descent depends on testosterone. Low prenatal androgen levels leave one or both testicles inside the abdomen or groin. People with Kallmann syndrome almost always have lack of secondary sexual characteristics, like lack of facial and body hair. About Hitler, there is no reliable evidence that he had reduced body hair, reduced facial hair, or sparse secondary sexual characteristics. He shaved his face daily because of his distinct moustache style, not because he lacked beard growth. Photos from his youth show normal male facial hair and normal hair distribution. Nothing suggests androgen deficiency. In females, there is breast development problems, and in males there is lack of voice deepening. There is also lack of muscle mass, because testosterone and estrogen remain very low. In women, there is no menstruation, and in both sexes, infertility happens in about 90% of cases. About Hitler, he did not have any children, but it is unknown whether this was because of infertility or because of choice. And about his micropenis, there is no reliable evidence. There were some autopsy descriptions about undescended testis and micropenis, but these were made by Soviet doctors, and it is unknown how reliable this data is or whether it was motivated by politics. And another sign of Kallmann disease is low libido, but Hitler's relationships with women, Jelly Raubal, Eva Braun, indicate normal libido. Kallmann patients normally have near zero libido without treatment. To summarize, there is no confirmation that Hitler had this mutation. But even if he had it, only about 50% of people with such a mutation will develop symptoms. Kallmann syndrome begins long before birth. It starts in the early weeks of fetal development, when 2 groups of cells must travel to their final destinations. One group becomes the olfactory bulbs, which allow us to smell. The other becomes the GnRH-producing neurons, which control puberty, fertility, and sex hormone production. In a healthy pregnancy, these cells start in the upper nasal region and slowly migrate toward the front of the brain. They move along tiny pathways, guided by molecular signals. In Kallmann syndrome, this journey does not happen correctly. The cells stop halfway or never reach their target. The reason this migration fails is almost always genetic. More than 30 genes are already known to be involved, and each of them plays a specific role in guiding cell movement, building neural pathways, or shaping midline facial structures. Different genes create different patterns of symptoms. Mutations in ANOS1 are strongly associated with mirror movements, where one hand copies the motion of the other, because this gene helps form the motor pathways that separate left and right body control. Variants in PROC2 and PROC2, the genes suggested in Hitler's reported DNA findings, affect the chemical signals that guide olfactory and GnRH neurons during migration. When these signals fail, both smell and hormonal regulation fail. But there is also no evidence that Hitler had smell problems. The disease can be transmitted genetically in different inheritance patterns. Sometimes autosomal dominant, sometimes autosomal recessive, and some of the genes follow X-linked inheritance, which is why it is more common in males. And in many cases, the mutation is de novo, meaning it appears spontaneously in the embryo with no family history. This is why some cases occur in families, while others appear completely randomly. An important detail is that the severity of symptoms depends on which gene is affected, how strong the mutation is, and whether other genes compensate for the loss. For diagnosis of Kallmann syndrome, two criteria must be met. First is delayed puberty, and second is loss of smell. The child does not enter puberty, no hair growth, no deepening voice, no breast development in girls, no genital enlargement in boys. Gonadotropins are very low in the blood, and testosterone in boys and estradiol in girls stays extremely low or near zero. Doctors often test for genetic mutations, but genetics is not required for diagnosis. Even today, in 30 to 40% of confirmed cases, no mutation is found because many genes are still unknown. Once the diagnosis is clear, treatment focuses on replacing the hormones the body cannot produce. In males, this is testosterone therapy, which deepens the voice, increases muscle mass and bone density, restores libido, and brings normal secondary sexual characteristics. In females, treatment is estrogen, followed later by progesterone, which stimulates breast development, protects bone health, and brings menstrual cycles. These treatments mimic natural puberty and allow normal adult development. If the person wants children later, treatment changes. Instead of testosterone or estrogen alone, doctors use gonadotropin therapy, injections of luteinizing hormone and follicle-stimulating hormone, which stimulates sperm or egg production. Another option is pulsatile GnRH therapy, which delivers GnRH in natural rhythm and can restore fertility. About 70 to 90% of men can produce sperm with treatment, and almost 80% of women can ovulate. Infertility in Kallmann syndrome is often treatable. The prognosis is excellent when treated. The condition does not shorten life, and it does not affect intelligence or personality. Once hormone therapy begins, physical development progresses normally, and psychological well-being improves. The only long-term need is continued hormonal support, since the genetic defect stays. A surprising feature is that in 10 to 20% of cases, the hormonal system partially recovers in adulthood, a phenomenon called reversal, where remaining GnRH neurons start working again. Some patients maintain hormones without medication or regain fertility spontaneously.